So picking up on some stuff that we did earlier, again, we're interested in pediatric obstructive sleep apnea, so you've seen this slide. And in this part of the talk, the aim is to talk about how clinical parameters from obstructive sleep apnea correlate with image-based CFD biomarkers. We've looked at different endpoints. One is what is the gauge pressure, minimal gauge pressure within the pharynx. Second would be different pressure differences or pressure drops. Third is flow resistance, which comes from that, but it's normalized by the flow rate. And then we'll talk about airway effective compliance and how we do that. And then the other thing is thinking about CFD biomarkers that might be related to surgical outcome, and we have some intriguing data there. So the methods, I think I've talked through this enough just to say we use rhinomanometry to get roar coefficients. We've got patient-specific flow rates. We have dynamic imaging, so we can see this change in shape of the airway during normal tidal breathing of awake subjects. Segmentation I've talked about, and then we do image-based CFD, and if you have questions, maybe talk to me afterwards about that. And then in post-processing, we have myriad different possible biomarkers or endpoints, and we're thinking about what's relevant. So typically, to reduce the number of variables, we take average pressures over about 100 milliseconds of unsteady flow simulation at peak expiration and at peak inspiration flow. And then we look at typical cross-sections in the nasopharynx, flow coming in from the choanal, at the velopharynx where there's maximal airway restriction usually, the retrolingual oropharynx, hypopharynx, and then our outlet condition at the trachea. And when we're looking at these unsteady dynamic images, we can get up to 10 data points for each of these cross-sections that are different times during the flow cycle. So if this is time, and we have the inspiratory phases, and say 5 or 6 of images correspond to the inspiration in this patient, and another 4 are expiratory flow. There's the measured flow waveform for this patient. And then in different cross-sections, we see different patterns. So here in the retrolingual oropharynx, it's the biggest cross-section, and it kind of is either you could say in phase or out of phase with the flow. So during inspiration, it's getting smaller. Expiration, it's getting bigger, and so it's linked to, positively correlated with the pressure fluctuations that we would calculate. The other cross sections are actually somewhat active. When the patient's breathing in, the area is a bit bigger, and when the breathing out, a bit lower, and that's a typical pattern that we've seen. And then the degree to which this happens and the degree to which the pressure is loading that gives us different compliances. So here's a pair of examples. We go back to the oropharynx, looking at 10 phases. Now I'm looking at the interluminal pressure. So we run the CFD model. We've got the pressure field, and this is the pressure excursions, and then the cross-sectional areas over here. So oropharynx, it behaves passively, we would say. This line has a positive slope. And then here at the velopharynx, which is the smallest cross-section, that slope is negative. The velopharynx is being pulled out as the patient breathes in. It's too much computational time for us to usually do 10 points, so we usually just go maximum expiration here to maximum inspiration on this side and get a linear compliance for each patient. So we would say if we get a negative slope for the compliance, which I'm going to stick here, so the compliance is just delta P over delta A. Negative slope means essentially active muscle tone dominates. Positive slope means a more passive response dominates. Okay, so I've got enough time to go through several different types of studies. Our earlier studies, I'm now coming back into results. This is a set of 15 age-matched patients, and we're looking at what significantly correlates with the severity of obstructive sleep apnea. And for us, we've been using for a severity the apnea-hypopnea index. That is, how many times per hour is there significant flow reduction and a drop in oxygen tension during the sleep study, or a complete cessation of flow and faster drops in oxygen tension. So we compare that number, the AHI, to a variety of different CFD model outcomes. The ones that significantly are different between kids with OSAS and with versus normals, and which are also correlated with the severity, that is, they correlate with apnea-hypopnea index, turn out to be, first of all, local pressure drops. So an example would be, let's go back here. So an example would be something we would call delta P TA, that is through the tonsils and the adenoids of these kids. So this is a kid with apnea. I'll go back to this picture again. The tonsils are sitting here. The adenoid is pushing down here on the nasopharynx, and the soft palate runs along here. And that gives us a pretty restricted zone here through the velopharynx. And we say, well, how much did the pressure drop from the choanine through the velopharynx? And so a pressure drop like that, or similarly, total pressure drop choanine to the trachea, those correlate positively with the presence of disease and the severity of disease. Similarly, if we normalize by flow, we get pharyngeal resistances localized. And to some degree, the max velocity, which we would see in this region, also correlates with the severity of disease. Surprisingly to us, things that represent the total load, and also the things that represent the biggest fluid mechanical influence on the pressure in the airway, are not significantly correlated with the severity of the disease. So that includes nasal resistance. We do see an effect of nasal resistance if we look at a large enough group of patients, but it's much less, it's much lower statistical significance. And so in the group that we've done CFD on, we don't see a correlation between nasal resistance and the presence or severity of disease. Similarly, the gauge pressure, so the minimal pressure loading the airway wall, does not seem to be correlated with this, even though you would think that's what the airway is fighting against to stay open. I can't tell how much time I have left because this is
About 7 minutes.
what, 7? Okay. We went on then to study the same biomarkers in patients with polycystic ovarian syndrome, or of the same group, a matched group of girls without polycystic ovarian syndrome. And in addition, in those patients, we were doing dynamic imaging so we could look at the compliances locally. So we saw very similar patterns, that the drops in pressure, the resistance to flow, both in inspiration and in some cases expiration, are significantly correlated with the severity of obstructive sleep apnea. And then if we look at the compliances, which is the bottom of my data table over here, we see the effect of compliance in one zone, that is the nasopharynx, the top zone, is just barely significantly correlated with the AHI in these patients. The other zones, no. It's interesting to note, we see over the group of patients in the oropharynx, we get positive compliance, that is passive-like behavior. Other cross-sections, negative compliance. So we think that's telling us something in a rather complicated way, maybe. We went on to, we started taking PCRIT data for these patients in the lab, and so we have 12 subjects where we've matched up PCRIT data and CFD data, and we see that, as expected, the PCRIT correlates with the severity of apnea. The compliance of the nasopharynx also correlates with a negative slope with the severity of obstructive sleep apnea, and these two variables, the PCRIT measurement in the patient and the CFD-derived data, that is the nasopharynx compliant, have a very significant correlation. So we think overall that what we're seeing in the CFD studies is that there's an overcompensation for the pressure load in patients who have sleep apnea, but they're awake. And we're seeing sort of a hyperactivity of the upper airway, and that seems to correlate with patients who, when they're asleep, are having the airway collapse. The other study that I wanted to talk about today is a pilot study looking at the effects of adenotonsillectomy surgery. We have before and after images of 10 subjects, and we thought that CFD model might be able to correlate with the outcome of the surgery. So I'll show 3 example patients. Each case on your left is pre-surgery and on your right is post-surgery. And so we see before surgery, we have a wider range of pressures in the airway. You can see anatomically how much more restricted the airway is here. Here again, the imprint of the tonsils here and the adenoids back here. And then once that's widened up, the overall pressure range drops significantly. The location of the highest pressure gradient moves down to the hypopharynx, where it was before in the velopharynx over here. So that looks good. Two more cases. Here's one where there's, relatively speaking, a lateral constriction has been relieved by the surgery. Overall, the increase in pressure in the airway is not that great here. And then here's a pretty severe one that had a much better influence. And this one there was always pretty severe nasal resistance in this subject. When we looked at this data set, we found that if we normalize the severity of the pressure drop or the resistance going through that velopharynx region, so from the choanal to downstream of the velopharynx, if we normalize that and compared it to the relative decrease in the AHI, or the severity, we got a significant correlation between those two variables. And that was significant in spite of the fact that some of the patients don't seem to fit the pattern. So we have patients over here where the surgery was, basically this side is, the surgery is not successful. These are the ones we're probably most interested in. Whereas where surgery was successful, this is completely successful, this is somewhat successful. We have almost a linear correlation here. So we think that CFD could be useful in predicting the outcome. And it's important because, actually it's not so visible here, but if we look at the whole data set, there's a lot of variability in what the surgeons are taking out in terms of the adenoid. They're reluctant, at least in our clinical partners practice, they're reluctant to take out too much of the adenoid. They think it's kind of risky, so they leave a lot behind sometimes. And so we might be able to justify or motivate them to take more in some cases than in others based on what we think would happen with a model. So that's intriguing. So if we think that CFD is useful for obstructive sleep apnea studies, the promising trends are between pressure gradients in the pharyngeal region of the upper airway and clinical endpoints and how those change if we change the anatomy in some way with surgery. And also we're intrigued by the fact that the nasopharynx compliance seems in some ways to tell us what happens in a P-crit in these patients. So we're now trying to implement this in a larger longitudinal study of obese children where we're facing the challenge of doing dynamic MR imaging in sleeping children. And we will have a 2-year follow-up on these, and some of these will also have surgery. So I think that's it, and I hope I haven't used too much time. Thank you.